Good afternoon, professors and doctors. We would like to give our warmest welcome to the professors, especially Sobri, Professor Sobri, for our uh, one of the two professors that are going to present a lecture this afternoon. And thank you for being here, Professor Sobri.
Thank you.
We are grateful that you are available to be our lecturer for this afternoon session. I would like also I would also like to greet Dr. Indrastuti as the chairman of the Radiology residency program in Medical Faculty Universitas Brawijaya. Thank you, Dr. Indrastuti, for the chance of uh, participating in this 3-in-1 guest lecture this afternoon. And I would also like to give our warmest welcome to Prof. Yun as the chairman of the 3-in-1 radiology lecture. Thank you very much, Prof. Yun, for the opportunity so that we can learn a lot about two very interesting topics that are stroke imaging and pediatric imaging. And as we know, those two topics are very challenging for us radiologists and for us medical students, radiology residents. So we are grateful that we can have two amazing professors to give us lectures about neuroimaging and pediatric radiology. Okay. And before we go to the lecture, we can start our afternoon meeting with a prayer. The prayer begins. we're finished. Okay. For now, uh, I think we are going to proceed to the lecture. So there are going to be two lectures for today. The first lecture is going to be presented by Professor Sobri, and as an introduction, Prof. Sobri is a professor that is focusing in neuroradiology from University Putra Malaysia. So we're going to hear a lecture from the very expert in neuroradiology this afternoon. And this is yeah, I think we can proceed to the lecture, and the time is yours, Professor Shafi. Thank you very much.
Thank you. First, I would like to thank Prof. Yuyun and Dr. Agung and Panatia of this program for including me, also Dr. Indra, for including me to give the lecture. I understand it's a series of lectures, so I will this time I will try to focus more on our experience, which is doing MRI in acute stroke. So this is not a routine imaging procedure in many centers, but in some centers or in some of your cases, you may be able to get the experience of MRI in acute stroke. Saya akan bicara dalam English. Kalau ada pertanyaan apa-apa, mohon teruskan untuk bertanya. Boleh di message ataupun terus kemukakan soalan. So saya will share my screen. Okay. I'm Dr. Sobri Muda from Hospital UPM, University Putra Malaysia. The hospital is actually very small, only 400 bed compared to your hospital, probably more than 1,000 bed. The hospital is quite close to the Putrajaya. Putrajaya is the administrative capital, sepertinya IKN di Indonesia. Cuma Putrajaya is very close to Kuala Lumpur, just between the international airport KLIA to Kuala Lumpur. So we work in a multidisciplinary team. So for radiology, we are inside the team which consists of neurology, emergency physician. There's also neurosurgery, and we are inside. We are doing the diagnostic and neurointervention. our radiology practice is a little bit different because we have intervention clinic. So we do see patient, not like the usual diagnostic radiology where they only see the patient during the procedure. Um, we also have daycare, meaning that patient who come for procedure will be admitted for a day to our daycare site, where after the procedure in the afternoon, we discharge the patient. So we have the rights to admit and discharge patient. And we have started the hospital in 2020, which is now is only 4 years old. So it's a very new hospital. And our niche is, one of the niche is stroke and neurovascular. So our team do most of the work, like 80% of the work is related to stroke and neurovascular. And we adopt MRI first policy for our hyperacute stroke, meaning that all the cases who come for acute stroke, we will consider MRI. If a patient cannot have MRI for whatever reason, then only we will consider other imaging. Okay. This is to share some of our papers that we publish related to how we start our service. So for stroke, I have to explain a little bit how we decide for the neuroimaging. Usually, when the patient arrive in the emergency department, or the patient refer from outside to our center for neurovascular or stroke, we categorize the patient as code red and code yellow. So when it's code red, the triage usually based on timing, onset, or within 6 hours. If beyond the 6 hours, up to 24 hours, we code as yellow. Beyond 24 hours or beyond 24 hours, we code as green, code green, and the imaging is not urgent. So for code red and code yellow, we will try to image in the we will try to image within the stipulated time according to code. And for code red, we will always try to achieve 20 minutes door to imaging, meaning that when the patient arrive, within 20 minutes, the patient should have imaging done. So in our case, because we do MRI, so the MRI has to be performed within 20 minutes. But most of the time, we didn't achieve that. Most of the time, we managed to image the patient within 1 hour. The average, if I'm not mistaken, is 45 minutes, if I'm not mistaken, from the door to the imaging. So for code yellow, we will try to achieve the similar time, but we are more flexible. Okay. So this is one of the paper that we publish, and you can see the neurologist. This in this picture, the neurologist actually assisting giving IV thrombolysis in the MRI suite. So when we do MRI in acute stroke, after certain sequence, usually after third sequence, we can decide already whether we should thrombolyze the patient or we should thrombect the patient or just medical treatment. So if it is for thrombolysis, we usually will stop the examination for a while once we already decide, and then we proceed with thrombolysis while the patient is still in the MRI suite. So this is our published stroke protocol. Usually, if we do DWI ADC, if there is suspicious hemorrhage, we usually jump to SWI, or in some centers they use GRA, the gradient echo. Okay, we perform also other sequences like vessel wall imaging. We do perfusion imaging, but not so routine. And there are other imaging to see the vascular, other sequence to see the vascular. Okay. I highlight this article to highlight that some other centers, especially in Europe, have adopt MRI first policy also. So, but we are not encouraging others to do because it's quite difficult, and it's easier to have CT done compared to MRI. But I want to highlight this to say that it is not we are the only one who's doing. It's coming as a trend. And in some other countries like South Korea, also adopting MRI first policy for acute stroke. So you can see in this paper, during office hours time, in France, as high as 90% of centers actually adopt MRI first, but after outside from office hours is lower. This is our statistic in 2022. The numbers is not too high, but as you can see, majority or more than 60% of our MRI for acute stroke is performed during outside from office hour. So it's performed in the middle of the night most of the time. Okay. I will go to the sign and symptom, to the sign of MRI in acute stroke. I think this will benefit more the radiology and also probably medical student. So for radiology, it is important to see or to try to identify certain sign in acute stroke MRI. One is flare vascular hyperintensity sign, or we call it flare hyperintense sign. Is identified actually as early as 2018 or 2017, if I'm not mistaken. There are some papers in early 2000 already noted the flare hyperintensity sign in acute stroke. So if you can see in this case, this patient, 60 years old, I think relatively healthy lady, but she presented with medium vessel occlusion. As you can see on the MRA, the left side, there is a occlusion at the M2 branch, middle cerebral artery, M2 branch. The M1 branch, you can still see quite okay on the MR angiography, but the M2 is already occluded. So on flare, you can see the hyperintensity sign. You can see that hyperintensity sign is actually representing the slow blood flow, or probably stagnation, or the stagnate blood flow in the M2 branch of middle cerebral artery. See in this case. So it's quite clear actually, the flare hyperintensity sign. If we want to compare with CT, it's a little bit like CT hyperdense sign, but normally CT hyperdense sign you can only see in a big vessel, and you do not see in most of the patient. But for the flare hyperintensity sign, in a patient who have vessel occlusion, almost always you will be able to see, including the distal, relatively distal vessel, like in this case, M2 segment. So this is the same patient. You can see this is the post thrombotic. This is the post thrombotic. This is another patient. It's quite recent. This patient presented to us, I think last week. No, 2 weeks ago. So you can see the flare hyperintense sign. So this is involving the distal M1 and also M2 segment. You can see in the arrow, and the MR angiography, you can see the paucity, which means that there is no vessel signal at the distal M2 region and also M3 region. The other sign is the prominent vein sign on SUI or on susceptibility weighted imaging. In some scanner, they name it gradient echo or GRE, depending on what machine that you use. So in prominent vein sign, the pathovisio is due to compromised blood flow. When the compromised blood flow happen in acute stroke, when there is occlusion, there will be increased deoxygenated blood. So when there is increased deoxygenated blood, you will see a more prominent vein. So because the deoxygenated or deoxyhemoglobin cause blooming artifact in gradient echo. So in SUI, it cause significant blooming artifact. So that's why we can or we noted the vein which drain the poorly supplied part of the brain become more prominent. In this case, you can see quite clearly you can see quite clearly wait, sorry. This one.
Oh, yeah. Minimize.
Oh. Sorry, this okay. You can see okay. You can see quite clearly the prominent vein on the SWE, and this case after the thrombectomy, we repeat the MRI at day 5. You can see the loss of the prominent vein sign because the deoxygenated blood is already equal between the left and the right side. This one you can see on the right side, the before thrombect and after. So you can see it's not so clear in this case compared to the previous case. This patient, 71 years old, this is a quite recent case also. So you can see the prominent vein sign on the SWE with many yellow arrow. And you can see even the deep vein, the deep draining vein also appears prominent because of increased deoxygenated blood. Okay. Clot sign. The same patient again. You can see the first image. So this patient actually had clot in the distal M1. So we did thrombectomy. We can see the clot. So you can see very clearly the clot. So we do see this quite common or in probably more than half of patients who have large vessel occlusion. So we can see the clot quite clearly in the SWE sequence of MR. So it helps us because we can identify the clot better. So it helps us to plan the treatment better, whether we should be very aggressive or we should use a different device. So we can see the clot quite clearly. So if there is no clot, but the patient still have occlusion, we probably will think of other causes also like intracranial artery stenosis. So which in those cases, maybe we are a little bit cautious on the treatment. If we cannot take out the clot, and we usually do not attempt too many times because it can cause complication. We maybe have to use balloon angioplasty to try to open the vessel. Hemorrhagic DWI sign. So one of the issue is identification of the bleed in acute stroke. So this is some of the opinion in many centers which say MRI is not suitable for acute stroke because you cannot rule out bleed, which is not so correct because in our experience, we can identify clot, we can identify hemorrhage much better than CT, especially in SWE sequence and in some of the small bleed, we can identify with SWE. And in acute stroke MRI, we normally start with DWI sequence, DWI ADC, and we can show that hemorrhagic infarct, even in DWI ADC, we are able to identify already the bleed. So it is not like until the gradient echo only we can identify the bleed. So on the first sequence, we can normally, or in most of the cases, identify the hemorrhagic stroke from the beginning. So if you see in this case, is one of our case who had bleed. You can see in the first two sequence, in the first two image is the DWI and ADC. There is hyper intense CT rim with incomplete hypointensity rim. So this is quite typical presentation of or features in DWI ADC for patients who have hemorrhagic bleed in hemorrhagic stroke. And you can see this patient, the SWE and also the SWE face confirm that there is a bleed. And usually in our center, if patient have bleed, we will update the surgeon, the neurosurgeon, and the neurosurgeon will request for CT, even though we already highlighted that there is already confirmed bleed in the MRI. But for this case, just to illustrate that the CT was done immediately after MRI. So you can see the identification on the DWI ADC of the parenchyma bleed. The intraventricular bleed may be not so well seen on the DWI ADC, but it can still be picked up very well in the other sequence, especially SWI sequence. In this case, similar like the other case, we do the MRI and then we identify the bleed. You can see in the DWI and ADC sequence, is quite clearly seen the hypo intense rim with heterogeneous hyperintensity areas. So this is quite typical and similar, and in the ADC is the other way around. So you can see it's proven in the SWI sequence, and the same CT, the same patient has CT done almost immediately after the MRI, because the surgeon requests. So you can see even on the CT, the hyperdensity is a little bit subtle, but on the MR, on the DWI is very obvious. So you don't need a senior guy to identify the hemorrhagic stroke using MRI. Pregnant sign. So I'm trying to show this patient. She presented with a young patient presented with code red mismatch. So we thrombolize the patient. On the SWE, there is no bleed. And we give contrast. You can see the hyper intense enhancement of in the vessel wall imaging, following the vessel which is not identified on MR angiography. So meaning that this vessel has no flow. Has no flow, but you can see the vessel is enhanced, including the wall on the vessel wall imaging. So this is among the features that we see quite often, and we name it as stagnant sign. So we are quite clear this is because of a stagnation of flow or reversal of flow due to the collaterals, or stagnation of flow due to the occlusion of the artery in acute stroke. ICAT plug sign. So ICAT plug sign, we want to identify also the enhancement of the plug in the vessel. Usually it's seen in the vessel wall imaging. I will show some of other cases before we go to the question and answer session. This patient, okay, you can see the DWI at presentation and at day 5, flare at day and day 5. You can see the SWE, the hemorrhagic transformation, but we want to show the vessel wall imaging. You see the stagnation. This is before, and then after at day 5, when the flow already restored because of the treatment, the stagnant sign resolved. Okay. This is also another case which before and after treatment, you can see the enhancement at the wall of the carotid, internal carotid, and the one post when we do at day 5. This patient, just to highlight the mismatch and the large vessel occlusion. You can see the one before pre, and this is the MRA is post. You can see the prominent vein sign. You can see also the stagnant sign, and post there is no more enhancement of the stagnant sign and reduction of the prominent vein. Different patient, but similar features. So the prominent vein sign is quite clearly seen actually on the MR. Thank you.
Thank you very much for the comprehensive lecture, Professor Reed, regarding the sequence used
Okay.
in identifying the acute stroke. So we can, so we now acknowledge there are several sequences that are useful to identify that is the flare, that we can find a hyperintense flare sign from the SWE. You can see the prominent vessel sign, and from the DWI and ADC, and also hyperintense center with hyperintense rim enhancement, and from the vessel wall imaging, especially the black blood imaging, you also see the problem, the pathological vessel. Uh, so we can now proceed to the question and answer session, Professor. Firstly, I would like to ask a question to Prof. Sophie. In
Yes,
in UPM, you mentioned that uh, the team may rely on the at least three sequences, MRI sequences,
yes.
to determine whether this patient needs interventional treatment or just conservative treatment. Based from your experience, what are the sequences that are usually most performed to determine the next step of the code activity performed?
Thank you. Maybe I can show some of the real case that we have done. Um, I'll try to find. Usually we will start like others also. We will start with the DWI, and then we will start with the DWI. Let's say I try to find one patient I can show you in our packs. I can uh, okay. I can share my screen again. You can see my screen
Yes, Prof.
is recorded.
Yeah, thank you.
Will take time a bit because this is a real case. The our packs is a bit slow. So you can see uh the DWI. You can see the DWI, the hyper intense.
Yes, Prof. You can see that.
Yeah.
Okay.
So we normally do this okay, quite routinely. Okay, so after the DWI, and then we will do the usual MRA also and flare. And we do MRA. Like in this case, is actually you can see the hyper intensity on the flare. It's not that obvious, but I just want to highlight even the posterior circulation also you can see the flare hyperintense sign. But we normally do the DWI and then we will do the flare and we do MRA. So like in this case, you can see the basilar artery flow is not seen because it's occluded, just a faint vertebra only. And this patient have posterior circulation infarct. And if we see the SWE, Gonna be a bit slow. This patient, the SWE, we don't see prominent vein sign that well. But for the vessel wall, you can see the enhancement of the basilar artery. So it's quite obvious. There are a lot of things we can pick up actually on the MRI. But the sequence is DWI routine, and then we do flare, and we compare. Usually DWI and flare, we already able to decide whether to thrombolyze or not. And then MRA, after MRA, we normally can identify whether we should consider thrombectomy or not. So after that three sequence, we already quite certain. So after the two sequence, when we decided to thrombolyze, usually we'll bring the gradient echo earlier as a fourth sequence, just to rule out bleed before they inject the thrombolytic agent. I think I hope I answer your question.
Thank you very much for the answer. It's clear that we can use the DWI flare for the thrombolysis decision making, and if we decide to perform a thrombolysis, we can perform additional sequence that's maybe GR8 to look for the bleeding before the thrombolytic agent is administered to the patient. And for the thrombectomy decision, it is we can use DWF and MRI to decide whether this patient needs thrombectomy.
Yes.
Thank you very much,
Thank
Professor,
you.
for the answer. Uh, okay, now from the audience, please you can open your microphone, doctors, and or you can type in the chat room so that I
Okay.
can read the question to you. Thank you very much.
Okay, can I ask
Oh, Dr. Bayhaki.
Prof?
Yeah. Okay.
Thank you, Prof, for the comprehensive lecture. That's opened our mind about the role of MRI in acute stroke. Yeah. I want to ask how to distinguish between acute thrombotic and chronic arteriosclerosis, Prof, if we see occlusion on MRA.
Oh, thank you. To differentiate between acute thrombosis or acute lesion and whether this occlusion is already due to the chronic cause. Our experience, we have a lot of difficulties also actually to differentiate. We have we have done thrombectomy in a few cases of large vessel occlusion, especially in the carotid. And then after we open up, then we realized that this patient probably already have the occlusion for some time. It's not the acute one. Maybe patient presented with, or patient have episode of low BP because of poor oral intake, and then it cause the exaggeration of reduction of supply because patient already have stenosis for a long time. So when the BP drop a bit, then the supply become less, then patient have symptom. And sometimes this patient presented with multiple episodes of TIA or transient ischemic attack. But when the BP go up again, then he's quite okay. But sometimes it become quite bad. So they presented to us. We do the MRI and we saw the occlusion. We try to thrombect, try to open, and then we realized that it's probably occluded for some time. It's a chronic lesion. From the MRI, usually it's a bit hard to differentiate between in the flare or in the MRA only. And if we have acute lesion, we assume that there is acute occlusion, or maybe before this is very severe, but now it become totally occluded. But other points which help us a lot is the plaque sign or the ICAP plaque sign. So when we do vessel wall imaging in patients who have MRA like occlusion and small infarct area, we don't see the stagnant sign in the vessel wall imaging, but we see we are able to see the enhancement of the plaque, the ICAT sign, enhancement of the plaque. So that's normally differentiate between is a chronic or is a very acute. So if you can recall some of the slide that I've shown, the on the stagnant sign, you can see the enhancement is kind of throughout the vessel. But for the ICAT sign, the enhancement is at the plaque only, at the point of the plaque only. So if it is stenosis at the M1 segment, you can see the enhancement at the plaque at the M1. And we see this quite often also in moya-moya disease. So in moya-moya, they tend to present with acute stroke, but their stroke usually is not that major. But on the CT scan or MRI or CT angio, you will see almost total occlusion. When you do the angio also, it's almost total occlusion. So in moya-moya cases, a lot of time when we MR, we don't see the stagnant sign throughout all the way. And so we just see the enhancement at the point or at the plaque. So maybe this is one of the way to differentiate. So we still feel even with the CT also you can't differentiate that well. So MR actually give more information whether it's chronic or very acute patient. So I would advocate vessel wall imaging or vessel wall imaging if you are not sure whether it's chronic or acute. I hope I answered the question.
Yes, okay. Thank you very much, Prof, for highlight of the importance of vessel wall imaging and ICAT plaque sign. Thank you, Prof.
Thank you, Dr. Bayaki, for the question. We can learn more about the vessel imaging's importance in acute stroke cases. Thank you very much, Dr. Okay, maybe from the audience, dear doctors, is there another question for Dr. Sofri? Please, you can open your mic or write down the question in the chat room. Thank you very much.
Good morning, Prof and Doctor. I would like to ask a question. I'm Johanna. I'm a radiology resident from Universitas Brawijaya. My question is, as we know, usually in stroke cases, MRE is usually performed without contrast. And my question is there any indications in stroke patients where maybe MRI examination needs to be performed with contrast, Prof. Thank you.
Thank you, Joanna. Yes, in a lot of centers, the MRI, MRE for stroke, they usually the sequence do not include contrast. But in some centers, when they do perfusion MRI, they usually use contrast for the perfusion scan. And in some scanners who have features like ASL, or they call it atrial spin labeling sequence. I think Philip call it atrial spin labeling also, or 4D trans. There are other sequence which is under the atrial spin labeling, where they give how should I say, the atrial spin labeling, they kind of label the blood flow coming from the carotid, and then they detect in the brain to see the blood flow which is already being labeled at the neck. So in this case, they can do the modified perfusion scan, which is not complete perfusion scan. If they use this, also they don't use contrast. So what I'm trying to highlight is not all MRI with perfusion scan or must use contrast. So that's why a lot of centers they don't use contrast. But the indication for the contrast, one is if you want to do a complete perfusion scan. So it's best to be done with contrast because of the CBV, CBF, and MTT evaluation is better evaluated with contrast. Second, if you are doing vessel wall imaging, in vessel wall imaging, usually you will perform with contrast. In some scanners, they do pre and post contrast. Some scanners, they just do directly post contrast. So that they can compare which part of the vessel wall enhance. So second. Third, if they want to see other lesion, maybe they want to exclude some other lesion, but otherwise you don't really need contrast if you want to identify presence of stroke or not, or you want to identify patient who have vessel occlusion or not. Thank you. I hope I answered the question. You can email me also if you have a question. You can email me later if you want. I have shared my email in the message box.
Thank you so much, Prof.
Thank you for the question.
Thank you very much, Dr. Johanna, for the question, so that we can learn about the use of contrast in the acute stroke imaging using the MRI sequences that are available. Thank you very much for the question.
Kalau mau nanya dalam bahasa pun bisa aja.
Okay. Okay. Is there another question from the audience? Okay, if there's no more questions for Professor Sobri, I'd like to remind all the participants that if you still have questions later, you can email Professor Sobri to the email that's already shared by Professor Sobri in the chat box. So you can freely copy the email and save it. So maybe later that if you have questions about acute stroke or maybe about neuro radiology, and you can directly email Professor Sobri.
Okay, thank you, Prof. Sobri.
Thank you very much, Prof. Sobri, for giving us valuable lecture so that we can learn a lot about the sequences that are useful in diagnosing and determining the next step of the patient's treatment in acute stroke. Thank you very much. I hope that we can use the knowledge that we get from Prof. Sobri to give better care to the patient with acute stroke. Thank you very much, Prof. Sobri. And before we jump to the next session, we would like to take a screenshot of the picture,
Yeah.
Prof. Sobri,
Okay. Yeah.
Prof. Sobri, and the participant.
Yeah.
Okay.
Thank you
I
very
will-
much for inviting me as the guest lecturer. I'm looking forward if there is any other series because the stroke and neurovascular imaging series, there are a few more lectures inside. If we have time later, because there are the angio and also other diseases. And I'm honored to be able to share this platform and give lecture to Brawijaya student and also medical student and also colleague. And especially thank you, Prof. Yuyun and Panatia. I appreciate it very much.
Okay. Thank you very much, Prof. Sobri, for being here to give us a beautiful lecture. So, excuse me, professors and all dear participants, we would like to take a screenshot in this current session. So please, if you mind, please open up the camera. So now we would like to take the first screenshot in 1, 2, and 3. Okay. Now we would like to take a second page screenshot in 1, 2, and 3. Okay. Now we would like to take the third page screenshot in 1, 2, and 3. Okay, and now for the fourth page in 1, 2, and 3. Okay, and now the final page is 1, 2, and 3. Thank you. Thank you very much, professors. Thank you very much, doctors, for the attention. And now we would like to jump to the next session, and we hope that we can host another meeting, like Professor said, so that yeah,
Forward.
can
Yeah,
learn, yeah,
I'm
learn
looking forward.
better.
Yeah.
Okay.
I'm looking. Thank you.
Thank you, thank you very much.
So I hope I can make a move first. Bisa ya untuk saya permisi dulu? Bisa?
Yeah, bro.
Yes, yeah, bro.
Thank you, bro.
Yeah.
Thank you.
Yeah.
Thank
Thank you,
you.
Prof.
I hope
Sobri.
to see
See
you.
you.
I hope I can I have opportunity to come to Brawijaya, but so far haven't
Yeah.
able to find time yet.
Okay. We hope that we can see you soon, Professor Ibrahim.
Okay. Thank you.
Okay.
Bye.
Thank you very much, Professor. Lee.
Thank you very much, Prof. Sobri. See you in Malang.
Okay, I would like also to remind all the participants that we also have the second session of the lecture this afternoon that is going to start at 12 o'clock in the afternoon, waktu Indonesia Barat. So if you want to be idle first, it's okay, and we can join to Zoom later on at 12 o'clock of Indonesia Barat to hear the second lecture about the pediatric radiology, especially the vascular malformation in pediatric radiology. That is going to be presented by another spectacular presenter from the UK. Okay, thank you very much. See you soon. Assalamualaikum. Thank you.
Ya, terima kasih Kun, terima kasih panitia.
Assalamualaikum. Assalamualaikum warahmatullahi taala wabarakatuh.
Welcome. Welcome, Prof. Hamzaini. Thank you very much for being here and being our presenter and lecturer for this afternoon session, Prof. Hamzaini. Thank you very much.
Thank you. Sorry lambat sikit, tadi saya ada problem. I got some problem with my because my presentation I put in my laptop, so I have iCloud. So my iCloud takes the time to download to update my presentation. So that's why it's a bit lambat sikit lah. Sorry. Okay.
No problem,
Kun,
Prof.
thank you, Kun.
Thank you, Prof. Okay. Good afternoon, Professor Hamzaini. Good afternoon, my dear lecturers from Universitas Brawijaya. Good afternoon, all dear participants in this afternoon session. Please let me introduce myself. I'm Hari Kuntoro, a radiology resident in Medical Faculty Universitas Brawijaya, and I'm this afternoon session's moderator for Prof. Hamzaini's lecture, vascular abnormalities in pediatric imaging. Okay, there are going to be two sessions in this afternoon's meeting. The first session is the lecture by Professor Hamzaini, and the second session is the question and answer session. So you are welcome to give the questions, whether by opening up your microphone or by typing the questions in the chat. Okay, so before we start the second session, let me introduce Professor Hamzaini first. So he is a professor in the University of Malaysia, especially in pediatric radiology division. So he is the master in pediatric imaging. And this afternoon, we're going to witness a presentation from the pediatric radiology master. So I know that we're going to learn a lot, especially in vascular abnormalities after the session. Okay, so let us start the lecture for this afternoon session. And Prof. Hamzaini, the time is yours.
Okay. Thank you very much, Kun, for the nice introduction. Let me share my presentation. Can you see my presentation? Can you see
Yes.
my presentation? Okay.
Yes.
So basically, initially I thought of giving a lecture on imaging in congenital lung malformation, but when I look back in my folder during my last year visit to Brawijaya in 2023, I think in November or October 2023, I have given that lecture already. So I thought probably too early, and probably you have listened to it. No point of me presenting again. Therefore, I decided to give this lecture. This lecture basically on vascular anomalies. And we noticed that a lot of people, even radiologists himself or herself, sometimes find difficulty in the terminology. How do we decide this is hemangioma or what, and how do we decide this is lymphatic malformation? Is it venous malformation? Is it AVM or etc.? So therefore, I decided to give this, and I think I have given almost similar topic to student Brawijaya, but it was long time ago. It was in 2018, probably. 2018, yeah. So by now it's already 6 years. So probably the resident who listened to this lecture already become a radiologist. Therefore, I thought, and I have not given this lecture before to Brawijaya. So And I also include some latest images that I encounter during my practice. Okay, so everyone okay with this? Okay, yeah. Okay. Okay. As I mentioned that vascular anomalies or any vascular tumor or vascular malformation, there are few classification. But to streamline so that we understand, we are talking about Kun, is it okay if I talk all in English or should I mix? Today is English day. Is it today is the English day?
Actually, today is easy, but it's
Huh?
fine.
Sorry?
It's fine if you
Yeah.
in English
I
or
mean,
yeah.
I'm not sure because previously I talk in Indonesia, but I know Brawijaya are trying to train the student to speak in English. So, but if you do not understand, please let me know. I will explain further. So basically, vascular anomalies classification is important so that we are talking about the same disease. So if I say this is hemangioma, then probably Prof. Yuyun or Dr. Agong or Dr. Baihaki also think this is hemangioma. If I say this is venous malformation, so we basically agree because we have the same definition. Therefore, or classification. Therefore, I would like to highlight this vascular anomalies classification. You can go to this website, ISSVA website, where they have a very extensive classification of vascular anomalies. And a lot of people in the world are using this classification. And I thought this classification are more systematic, easy to understand, so that everyone will hear and will learn and understand. Then and then of course I will show some images and also a treatment and some challenges that we encounter during our treatment. So if you compare my slide with ISVA classification website, it is totally different because I want to simplify my presentation. In the website, there are a lot of tables, a lot of links, so you can go through later on. But when we are talking about vascular anomalies, basically vascular anomalies are divided into two. This is according to 2018 classification. But I just came back from ISVA conference in Madrid in April this year. So they already added one more, which is also again a lesion where you cannot categorize as vascular tumor nor vascular malformation. Therefore, I decided not to confuse you anymore. And they have not also has a concrete classification on the third one, but I decided to easy to understand vascular tumor and vascular malformation. Vascular tumor is a tumor, a mass. So all the names of this lesion ends with OMA. Contohnya hemangioma, okay? Hemangioendothelioma, also all omas. Apa lagi? A lot of ni. So this is basically due to a vasoproliferative neoplasm, and this is due to increased endothelial cell turnover. Compared to vascular malformation are basically abnormality of the vessel itself. It can be capillary, can be venous, can be artery, can be lymphatics. Okay, and sometimes it may be a combination of those. So it is not a neoplasm, it's not a tumor, but it is an abnormality of the vessel. So so this is again a simplified version of ISVA classification. So if you look at the tumor, it is divided into benign, locally aggressive, and malignant. For benign, which is most of the time you see this patient, more common to see infantile hemangioma. Sometimes, rarely you see a congenital hemangioma, and I have seen one tough hemangioma. Pyogenic hemangioma I have not seen. So but we have a Kaposi hemangioperineuma we have seen. And if you're talking about malignant tumor, vascular tumor in children, it is very, very rare. So I will not highlight them today. So on the other arm, there is vascular malformation. As I mentioned, it can be a simple, which can be either capillary, lymphatic, venous malformation, arteriovenous malformation, or arteriovenous fistula. And we may get also some combined, like capillary venous malformation, capillary lymphatic malformation, lymphatic venous malformation, or capillary lymphatic venous malformation, and so on. So and we also have some syndrome which associated with this vascular anomalies or vascular malformation. So for today's presentation, I will highlight this, which is more common. Of course, Kaposiform hemangioma is not common, but we have seen a few cases. Clipper tenone also not common, but I just want to highlight the cases today. Okay, what about the imaging option? What should we do when we have a case where we suspect vascular anomalies or vascular tumor? So, of course, you can do X-ray, but X-ray will not give you a lot of information. X-ray may show you some remodeling of the bone if the lesion affected the bone, or if the lesion has extended into the bone. So there may be some changes in the bone itself. The cortex may be thin, or there's some defect in the cortex and so on. And you may see some phlebolith in the case of venous malformation. In my practice, I always do ultrasound, which is quick and cheap. And you can do yourself, you can assess the patient, you can assess the lesion by yourself. Okay, you can touch the lesion. So, and I can also do compression. So in venous malformation, although it is not all venous malformation is compressible, but I would say almost 80 to 90% of venous malformation is compressible. Okay, if you see phlebolith on the ultrasound, then that is a good point for you to say this is a venous malformation. But if you do not see a phlebolith, it does not exclude venous malformation. Okay, and of course we will do MRI. Our next step. We try not to do CT scan because we have good access to our MRI, and it is less radiation, good for the patient, because this patient will need follow-up MRI as well for follow-up cross-sectional imaging. Therefore, we try to avoid radiation dose, high radiation dose to the patient. Okay, and and then angiography. When we do, let's say this is AV malformation, then of course we will do angiography. In the case of venous malformation, I will do venography. Okay, so basically, we can do angiography, venography for the diagnosis, and also treatment, and also assessment after the treatment. Okay, this is also again simplified imaging workup. And I focus only hemangioma, AVM, venous malformation, and lymphatic malformation. I can guarantee you that you will see at least, I would say, venous malformation, you will see about 60% to 70% of your case. Hemangioma, probably you see about 5 to 10%. Lymphatic malformation, probably 20 to 30%. AVM is again not common, but you'll see about 5 to 10%. So overall, if you remember this or you understand this, most of the time you would be able to understand or to get the diagnosis correct. Okay, first we do ultrasound. So basically, when we do ultrasound, we can decide whether there is any vascular flow within. And if there is any vascular flow, is it a high flow vascular malformation, high flow within it? Is it an arterial waveform? Okay. Is it a venous waveform? Okay. Which is a slow flow. Okay. And you can also look at the velocity of the flow. If it is a very flow velocity, then you know this is slow flow. Okay. So, and then after that, you go to MRI. So MRI, if there is a mass like lesion with vascularity within, then you can think this is as hemangioma. If there is no mass, so it's just a insinuating vessel. Cuma salur darah saja yang insinuate in between the soft tissue ataupun in between the tissue, the muscle, the subcutaneous tissue. Then you know this is with the, of course, with early draining veins, with the with the nidus, early draining vein. Then you know this is ABM. And then on the other hand, if you have a slow flow malformation or slow flow lesion, then you look at the enhancement. If there is no enhancement or there is only a rim, wall saja enhanced, then this is most likely a lymphatic malformation. Okay, but if there is enhancement internally, there are the cavity itself yang kita nampak bulat-bulat itu, tiba-tiba ada kontras di dalamnya. So we know this is a venous malformation because lymphatic will not have contrast inside the cavity. Only venous akan ada. Okay, so this again the signal intensity of the MRI, T1, T2, and postgadolinium. For hemangioma, iso-intent. For T2 is hyper-intent because it's very, very, fluidy, a lot of vessel, a lot of blood vessel di dalam tu. Jadi, bila kita buat, and the flow is not very high flow, therefore you will not see a flow void within the hemangioma. Okay, but again, it depends on the stage where you scan the hemangioma. In postgadolinium, of course, because dia ada salur darah yang banyak di situ, so you'll see intense enhancement. AVM, there's no mass, therefore you'll see a vessel, dilated vessel, either vein, dilated vessel of vein and artery. Then, because this is high flow lesion, therefore you'll see hypo or flow void vascular structure on T1 and T2, and of course it enhances. The vascular will enhance in post-contrast. Lymphatic, of course, there's no contrast enhancement. It is fluid, therefore hypo on T1, hyper on T2, and it may be enhanced or there's no enhancement at all. Kalau dia enhance pun dekat wall saja. Venous, they're mixed. Sometimes you'll see heterogeneous signal intensity on T1 and T2. Present a flebole is good for you because you know this is most likely venous malformation. And as I mentioned, kalau kita kasih kontras akan nampak ada enhancement di dalam. Okay, shall we go to our cases? Tumor. Number 1 is a vascular tumor. We can have a hemangioma, which is divided into infantile hemangioma or congenital hemangioma. First, we go to infantile hemangioma, which is more common than congenital hemangioma. Infantile hemangioma has a very classical natural cause. Okay, dia ada 3 stage. Stage yang pertama is proliferating. Dan biasanya infantile hemangioma namanya pun infantile, jadi dia tidak kelihatan waktu lahir. Ya, dia bukan congenital. Jadi dia lahir okey aja, tapi bila 1 bulan tiba-tiba ada bintik merah dan bintik merah itu rapidly increase in size. Sama, boleh nampak arrow saya? Boleh nampak arrow ke?
Yeah.
Ya, good. Kalau kita tengok pada graf ini, dia tidak ada masa lahir, tapi lepas itu dia terus naik mendadak sehinggalah umur dia antara 1 hingga 2 tahun. Lepas tu dia akan mengecut. Ini adalah behavior of infantile hemangioma. Okay, this is what we call the first phase is the proliferating. This is the involuting, and the last phase is the involuted. By 5 to 6 years, they akan involuted. Next is congenital hemangioma. This is more rare than infantile hemangioma, and it should be present at birth. Size-nya sudah cukup besar sewaktu lahir, dan dia dah mature masa lahir sudah ada. Ya, dan dia maksudnya mature, dia dah sampai ke peak dia. Then congenital hemangioma can be divided into a few category. Number 1 is rapidly involuting congenital hemangioma, which will resolve like this one. This is rapidly involuting congenital hemangioma. Sama juga dengan ini. Okay, lahir ada, lepas tu dia akan by umur 1 tahun hingga 2 tahun terus hilang aja, ya. Ada juga yang non-involuting, itu kita panggil niche. Kalau yang rapidly involuting kita panggil reach, dan partially involuting kita panggil pitch. So congenital hemangioma can be divided into rich, pitch, and niche. Okay. Okay. And this is example. Tengok masa lahir tidak ada. Lepas itu start dengan bintik seperti nyamuk gigit aja ya. Ini. Lepas itu terus membesar. Ya. So this is a very classical infantile hemangioma. Infantile hemangioma, we do not need any imaging. History is important. So kalau you tanya ibu, lesi ini sudah ada waktu lahir. Oh, tidak ada, dia kata clear aja mukanya. Tapi mungkin umurnya 1 bulan atau 2 bulan, mula ada bintik seperti nyamuk gigit, kemudian terus membesar. Itu memang typical infantile hemangioma. Okay. On imaging, kalau kita buat masa dia tengah mengganas, masa dia tengah grafnya tengah meninggi mau menaik itu, jadi kita nampak begini, kita nampak ada mixed arterial and venous malformation, venous component, and then we can see a dilated veins there, dilated draining veins, because there are a lot of feeding vessel, draining veins. So dia kadang-kadang boleh mimik seperti AVM juga ya. Okay. Selepas itu kalau kita, this is what we call proliferative phase. Lepas itu masa involuting phase, then you'll see this is the same patient. Nampak dulu nampak bulat-bulat hitam ini seperti channel vessel itu. Sekarang sudah tinggal sedikit aja, yang lain semua sudah putih, sudah jadi fat, sudah replaced by fat. And this is the end of our follow up, and then see this large vessel ini sudah kecut. Dan kebanyakan lesi ini adalah telah ditukar kepada lemak. So jadi ini dipanggil maturity phase. Okay. Okay. So what is the treatment? I think the treatment of hemangioma biasanya observation saja, sebab dia akan by umur 5 tahun sudah hilang ya kalau infantile hemangioma. Kalau congenital pun kebanyakannya yang akan ada adalah rich, rapidly involuting congenital hemangioma. Jadi biasanya observation cukup. Okay. Propranolol. Sometimes kalau lesi itu berada pada kedudukan organ yang important, contohnya di muka, nampak macam besar, anak itu nampak macam tidak cantik, dan orang akan kata ini apa ini, macam-macam lah. Bila kita pergi kenduri, pergi arisan, semua orang tanya ini kenapa ini anak ini kenapa bengkak mukanya. Jadi parent akan rasa lebih tertekan ya. Jadi kalau macam tu kita bagi treatment. Okey, yang lain tu steroid dan sebagainya itu jarang dibuat ya. Okey, this is our patient. Mulanya hidungnya sengit sebab ada infantile hemangioma, so we treat with propranolol, and alhamdulillah cuma tinggal sedikit dan hidungnya sudah simetri ya. So ini adalah ubat yang kita bagi, oral propranolol. Okey. Congenital hemangioma on imaging. So kalau kita fokus kepada lesi ini, nampak ini? Lesi ini adalah lesi yang berada pada awal, pada umur anak ini 5 bulan. Kita nampak dia hypo on T1, hyper on T2, and post contrast nampak tak? Dia avidly enhancement, homogeneous enhancement. So this is typical of infantile hemangioma. Congenital hemangioma. Sebab dia lahir sudah ada ya. Tapi lepas itu, lepas umurnya 1 tahun, kita scan lagi sekali. Sebab dia di samping itu, dia juga ada lymphatic malformation. Nampak ini? Ini yang ada biji-biji putih ini adalah lymphatic malformation. So, jadi selepas 1 tahun kita follow up MRI, kita lihat lymphatic malformation masih ada. Tapi lesi yang besar ini sudah tidak kelihatan. Sudah become very small, this one. Ya, sudah kecil. Tanpa sebarang treatment. Jadi kita tahu umur ini lahir sudah ada, lepas tu terus kecut. Jadi ini adalah contoh typical appearance without any treatment, they're rapidly involuting congenital hemangioma. Okay. Okay, next is Kaposi hemangioendothelioma. This is a girl, 2 months old girl, baby girl, presented with to us with increasing right forearm swelling. Okay. So, jadi masa presentasinya plateletnya sangat rendah. Plateletnya cuma 8 saja. Jadi kita tahu ini apa? Ini ada Kasabak-Merit syndrome. Di Indonesia juga disebut itu ya, Kasabak-Merritt syndrome. Platelet consumption. Ya. So jadi platelet disebab banyak platelet sudah pergi di tangan, jadi keseluruhan badan dalam salur darah itu plateletnya sangat rendah. So bila kita buat ultrasound, kita nampak soft tissue-nya, subcutaneous soft tissue thicken, intramuscular juga ada heterogeneous. Bila kita letak color Doppler, kita nampak ada a lot of vessel inside. But we don't see mass. We just see diffuse changes in subcutaneous tissue and also intramuscular. This is the muscle. Okay, so with the ultrasound, with the MRI, we suggest that this is a Kaposi hemangioendothelioma, and also because of the Kasabak-Merritt syndrome. And Kaposi hemangioendothelioma is known to be associated with Kasabak-Merritt syndrome. Okay, okay. Therefore, there's no treatment in terms of interventional, so we decided to give sirolimus. So this is after 1 month of sirolimus, this swelling has dried up, and you can see that the platelet has increased in number with the treatment. So we know that the patient responded very well with the treatment. And this is after a year, I think, after a year of treatment, you can see there's no lesion anymore. Okay, and we did a follow-up, yearly follow-up on MRI, and a few MRI follow-up shows no recurrence. But unfortunately, just last month, patient had a swelling again in the same hand, and MRI, when we repeat MRI, it shows recurrence. Okay, so we are planning to start again on sirolimus on this patient and to follow up. Okay, now we finish on one side, on the tumor side. We should go to the malformation. Any questions so far? So far, okay? Everyone understand? Joanna, you okay?
Yes, okay, Prof.
Okay. Okay, then we go to, of course, capillary. When we talk about capillary biasanya bukan di-treat oleh interventional radiology because capillary adalah salur darah yang sangat kecil yang kita pun tak nampak salur darahnya, jadi susah untuk kita nak buat sclerotherapy. Dan biasanya laser treatment by dermatology sudah cukup ya, sudah improve, sudah baik. So kita go to lymphatic malformation. Lymphatic malformation is a collection of lymph field channel. It present at birth, okay. Sometimes not noticed by parent. Cuma bila dia makin membesar, parent pegang-pegang dia, rasa ada ketulannya. Jadi bila buat ultrasound, nampak ada cyst. So swelling may be increased kalau dia ada infection ataupun ada hemorrhage dalam dia. Biasanya skinnya okay aja, tidak ada apa-apa changes ya. So the most common site adalah head and neck, extremities, axilla and also trunk. Okay. Again, kalau tengok pada yang merah ini, ultrasound tidak ada flow ataupun slow flow, biasanya tidak ada flow ya. Post contrast there is no enhancement ataupun kalau ada pun dekat wall dia saja. So this is a lymphatic malformation. Okay. Okay. So again, I don't want to repeat this. So basically this is, so nampak macam ni lah ya. So this is a hypo intense on T1, hyper intense on T2, and dia ada wall, kalau ada enhancement pun ada wall enhancement ataupun septal enhancement. Okay. Why cross-sectional imaging is important? Number one, sometimes what you see not representing the real issue. So you probably see just the tip of the iceberg, number two. Number three, you don't know what is going on in the deeper structure, whether airway is compromised, is this lesion surrounding the airway or not, okay? Okay. So if you look at this patient, you know that there is extension deeper retropharyngeal or retrolaryngeal extension. Therefore, there is a risk of airway compromise if the lesion is getting bigger. Okay, on ultrasound, it is hypoechoic. Yeah, on ultrasound. And when you put color Doppler, this hypoechoic does not show any color Doppler, okay? So lymphatic malformation can be divided into macrocystic, microcystic, and also mixed macro and microcystic. Okay, so the definition, what is the definition? If you look at the literature, they decide or they make as 2 centimeter as the cutoff point. If it is more than 2 centimeter, is macrocystic. If it is less than 2 centimeter, is microcystic. And what I decided is basically as long as I can puncture and I can aspirate the fluid, then I consider that as macrocystic. If I cannot puncture to the individual locule, then I consider that as a microcystic. Okay, so this is an example of macrocystic, large cavity with septation. And this is microcystic. You see a very tiny, small lymphatic malformation or cystic lesion. And this is a mix. You can get, you get here a large macrocystic, and also you get this microcystic, small microcystic. Okay. So what is the treatment? The treatment, we have given the patient OK432, we have given bleomycin, doxycycline. I think I got only 1 or 2 patients that we give doxycycline, and also alcohol. Alcohol, not many. I think probably about 1 or 2 patients that we give alcohol, because the alcohol, the patient will have a pain after the alcohol. How do we do it? So number 1, we do under ultrasound. We puncture, this is the needle, we puncture into the cyst, and then we aspirate the fluid out. Okay, the fluid is usually this color if this is a lymphatic malformation, and then we inject with sclerosing agent, either alcohol, either bleomycin, either OK432. So this is a study we did. And I'm sure some of you know Prof. Rosman. We did to on reviewing all the bleomycin that we give. So if you look at the complete resolution and good response, you would consider the success rate is about 83%. Okay, okay. And this is a response to bleomycin that we give to our patient. If we take excellent and good response as a successful treatment, then the successful treatment is about 86%. This is some example where this is a before and this is after, some residual, and the patient also this one will continue to get sclerotherapy or bleomycin injection. So this is a large lesion, and the patient had third injection. After third injection, there's no more lesion. The lesion has disappeared. Only some skin changes there. This is the interesting case. Huge groin lymphatic malformation came to us because patient don't want to go to school because number 1, he cannot wear trousers. If he wear a celana, celananya harus besar, dan kawan-kawannya juga ejeknya ya. So jadi dia tidak mahu ke sekolah, jadi dia dibawa oleh atuknya jumpa kami. So kita pun inject sebanyak 2 kali. Alhamdulillah, selepas 2 kali, this is the result. So the result show a significant reduction. But unfortunately, patient did not come to our follow-up. So this is a problem with treating vascular anomalies. Patient biasanya datang jumpa kita dulu. Bila sudah okay, dia tidak datang dah. Dan ini gambar saya pergi ke rumahnya sebab saya pergi ke rumahnya sebab saya mahu lihat apa responnya, kenapa patient tidak datang. Jadi saya pergi ke rumah, ambil gambar. So Alhamdulillah, dia kata dia sudah tidak datang sebab dia sudah pergi sekolah. Dia sudah boleh pakai celana, sudah pergi sekolah, tidak ada kawan-kawan ejeknya, sudah okey. So sebab itu dia tidak datang. Sebab ini kalau pakai celana tidak nampak ya. Yeah. So this is a baby, we did a fetal MRI. This is a fetal MRI. You can see that there is a huge lymphatic malformation at the neck and also the jaw. And some of the lymphatic malformation also extend into the airway. and there is a possibility that there might be some airway compromise. That's why we did an exit ex utero intrapartum treatment procedure. So basically, intubate the baby during the delivery itself, and we ventilated was wean off after 15 days. And what we did for this patient is we did not do a sclerotherapy, but what we did is we just aspirate fluid. I think about 350 cc of fluid coming out from this lymphatic malformation, and after that extubate the patient. Then patient was treated. Why we decided not to give bleomycin or any sclerosing agent, because we learned from this patient where the lesion also looks very external, but there is internal extension with the surrounding or possible obstructing the airway. When we give bleomycin or we give OK432, the lesion, the internal lesion become bigger and cause airway compromise. Therefore, we need to do a tracheostomy. That's why we decided for this patient, we don't want to give a sclerotherapy yet. Let the lesion become small, and the risk of airway compromise is reduced. Therefore, we decided not to give sclerotherapy. We give sirolimus for this patient. So this is the sirolimus that we gave, the 1 month during the sirolimus, just before. This is the MRI before sirolimus, and this is after 3 months of sirolimus. You can see that the lesion has become smaller, and this is about 1 year after sirolimus. So on clinical is also reduced, on imaging is also reduced to only small lesion at the jaw here. Yeah. And you can see the skin is also berkeremuk, ya. Sebab dulu dia distend, very stretchable, but now dia become ni. So this patient had a sclerotherapy. I also did sclerotherapy because this lesion is almost macam stabilized. Dia tak nak turun lagi selepas sirolimus. Therefore, we puncture, we aspirate, put a bleomycin inside. Alhamdulillah, the lesion becomes smaller. Now waiting for plastic surgery to do to remove the residual lymphatic malformation and to do a plastic surgery to make sure that this skin is removed and the patient is handsome looking. Okay, so next is venous malformation. Venous malformation is a thin wall dilated veins. This is because the abnormality is at the veins. So usually present at birth. May have some bluish skin discoloration. It is compressible. Compressible is important. Okay. Sometimes this lesion may become bigger, and because of thrombosis, because of infection. Therefore, and this lesion also grows with the patient. Bila patient membesar, lesion ini juga membesar mengikut saiz badan pesakit. So imaging, X-ray, see, if you see a phlebolith, therefore you know this is most likely venous malformation. On MRI, you see a phlebolith, multiple phlebolith within the dilated veins. On ultrasound, but what you see is a lobule of venous channel inside. And if you see phlebolith, then you know this is venous malformation. On CT, of course, but we don't do CT, but CT you see a phlebolith. Okay. So on ultrasound features, you see this oval shape, you see bulat-bulat di dalamnya. And this is a before compression, and this is compression. So it is compressible. So if there is a present phlebolith, compressible, and if you puncture, you aspirate keluar venous blood, then you know this is a most likely venous malformation. Okay, and flow, of course, you see some venous flow inside. So ini yang saya bilang tadi, maksudnya kalau kita cucuk aspirate keluar ini color, bukan venous malformation. Tapi kalau kita aspirate keluar ini venous blood, then you know this is a venous malformation. Okay. So 7-year-old boy, right intraoral swelling. You can see the lesion here. Bulat-bulat-bulat, ya. Nampak seperti venous malformation. Okay. So kita buat MRI. MRI kalau kita lihat di sini ada a lot of cystic lesion with air fluid level. Ya. And bila kita bagi kontras, see this one tidak ada enhancement, but this area ada enhancement. So we know this is a mix between lymphatic malformation and venous malformation. Okay. So treatment of venous malformation, polidocanol boleh, alcohol boleh, bleomycin boleh, but currently we are giving all this venous malformation with bleomycin, and it's safer, less complication. Okay, so how we do it? So basically we identify the lesion, puncture the lesion with the needle, and then we inject. We aspirate blood and then we inject. See, this is all alcohol or bleomycin. We inject into the lesion, and there will be some reaction immediately after alcohol injection. You see some solidification of this lesion. Okay, this is a boy who is 20, I think 22 years old. Came to me because of this swelling of the cheek. He is handsome, but he want to be more handsome because there is some asymmetry of the cheek. So we did an MRI. MRI shows hyper intense on T2 with presence of phlebolith. Ada phlebolith di sini, ya. So this patient did MRI in private hospital, in some other hospital, and then already diagnosed as a tumor. Was diagnosed as tumor, and the maxillofacial surgeon, dental surgeon, already opened from the buccal inside buccal mucosa. When they open, they look at the lesion. The lesion are very look like a dilated veins and bluish discoloration. So he don't want to remove it. He close it. He get opinion. Ask my second opinions. Then when I review the MRI, I said I don't think this is a tumor. This is most likely a venous malformation. This is MRI. So basically, MRI, what you see here, hyper intense on T2. And then in post contrast, you can see there is some locule has enhanced, some are not. So this is see this one. This is probably some enhancement there inside. So this is a venous malformation, compressible. This is during non-compressible. You can see some compressibility here. Yeah, okay. And we put color Doppler is a venous flow. So we did venogram. We puncture through the cheek, and then put a contrast, identify the lesion, and then after that we inject alcohol inside. Inject alcohol, and this is the result after post-sclerotherapy. Patient very happy, no more swelling, become more handsome now, and unfortunately, patient never come back to you. When they become handsome, they will not come back to you. When they are not handsome, they come to you. Okay, so I'm happy because it indicates that the patient is happy. That's why they didn't want to come for follow-up. Okay, AV malformation, basically a communication between arterial flow and also venous flow through a nidus. And this is also usually present at birth and grow with the patient. Okay. On color Doppler, you see a mix of venous, basically you see a arterialized venous flow. Okay. The flow is venous where you see low resistant arterialized flow. For example, if the lesion is located in the lower limb, usually the lower limb waveform is very sharp. Yeah, but in when you put your cursor in the venous drainage side, then you see a very high, like an artery, but the diastolic is very, the forward flow during diastolic, just like the ICA flow. Okay, so you know this is a AV malformation. This one I don't have to go through. So see the nidus here, the nidus. Okay, and you can see some arterial supply and some venous drainage. Okay, so this is the arterial supply from external carotid artery. See the nidus there. Okay, and this lesion was embolized, and you don't see this one. You see a draining vein. See the early draining vein here, and this one you don't see early draining veins. So you know that this lesion has been treated. Okay. Okay. Last, clippertronone. Do we have time, Kun?
Yes, Prof.
Yeah. Okay. Clippertronone this is the patient, a 4-year-old boy who presented with who stay in northern part of Malaysia. Went to multiple hospital in northern part. They did an embolization of the lower limb, but it getting worse. So basically, probably they block the artery. That's why the lesion become bigger, edematous, and sent to our orthopedic in our hospital UKM. The orthopedic already planned for amputation. Okay, disarticulation. So, and then my orthopedic colleague met me and he said, what do you think about this? And then when I look at the case, I said, maybe this is a clippertronone. I mean, clinically, overgrowth, limb overgrowth. And then why not we do MRI and assess? So clippertronone is a cutaneous capillary malformation, mainly capillary. They may have some pop vine. If you look at the lesion, some pop vine nevi, and limb overgrowth is a common feature, localized gigantism. Varicose vein or venous malformation may be a part of the clippertronone and lymphatic malformation as well. But when you have AV malformation in the component, then that is a clippertronone Park-Oeber syndrome because you have a venous AV malformation component. So this is a patient. We did a MRI. MRI basically just diffuse subcutaneous capillary malformation, and there is some lesion here which is bright on T2, and not sure which one is post contrast, but there is also a cystic. You see this hyper intense. This is a lymphatic component. So lymphatic component not predominant, but the predominant component is capillary, a bit of venous malformation, and also a lymphatic malformation. So therefore we treat with sirolimus. When we diagnosed this, I told my orthopedic surgeon, why not we try sirolimus? Patient may benefit and may not need any amputation. Good for the patient. Yeah. So this is a pre-sirolimus and this is post-sirolimus. So you can see significant reduction of the lesion. Patient start with this one, and then now patient can stand and walk at home. So I have a video where the patient is running, of course with limping, and because the lesion has become smaller. So we feel very happy, but unfortunately when we stop sirolimus, the lesion increased slightly. So we have to assess again whether the patient need sirolimus or not. Okay, some of our challenges. This is a venous malformation. You can see the scar here. Surgeon has removed the venous malformation during the child, when the patient is baby, and then but recur. So we did sclerotherapy. Alhamdulillah, the lesion significantly reduced in size. And if you look at if you compare the left and right side, it's almost similar. Okay, of course you see some dilated veins underneath this, but in terms of size, acceptable. So why? I mean, our aim must be very clear, because when you want to treat the patient, you must explain the patient. Our aim is not to remove the lesion completely. Our aim is to make cosmetically acceptable, reduce the symptom. If the symptom is pain and swelling, so we hope it will reduce the symptom. Unfortunately, mother wants some more sclerotherapy. And we did a sclerotherapy, developed a complication with the skin necrosis, and the patient has scar, another additional scar here. Okay, so you must be very clear with your patient. Tell them our aim should be agreed. We don't want to over-treat the patient. Okay, this is example a venous malformation where you raise your hand above the heart, it will collapse because this is a vein. Okay, so the patient came to see us because of this swelling, recurrent pain, recurrent swelling, not able to go to school. So when this lesion become big, it's really painful. And then we treat the patient. Unfortunately, we treat with alcohol, and the alcohol seep through the dermis under the skin and develop a skin necrosis. So see this blister, just like you burn something, because alcohol is very corrosive. So and the patient developed this skin necrosis. I'm quite worried during that time, but my orthopedic surgeon said, no worry, this is just a superficial necrosis, and the lesion becomes smaller, okay, as compared to previously. And then we repeat again. I think we do it again, and the patient also developed skin necrosis here, and alhamdulillah, finally, only scar, no more swelling, no more school holiday. Patient did not come to see me anymore. I miss all my patient. So this patient also did not come to see me. And quite some time already, I think probably 3 years, 4 years, I have not seen the patient. Okay, last component is not all multicystic lesion are lymphatic malformation. So this is a patient who had swelling in the neck. See this swelling? On MRI, you can see a cystic with septation. So we thought, oh, this is probably a lymphatic malformation in the neck. So on ultrasound, also similar. You see anechoic, no color flow. This is again on coronal view. So we have been treating this patient with OK432, bleomycin, alcohol. But again, you treat, improve, but recur. Treat, improve, recur. Treat, improve, recur until 2022. So basically, we start 2017 until 2022. So almost 5 years. And again, this is lesion, improve, recur, lesion, improve, recur. So this is just to highlight that the patient has recurrent, almost always recurrent. So we even do a puncture the lesion, put a contrast to see whether there is any communication with salivary gland, but couldn't find. So at the end, and this is our one of the last ultrasound follow-up, then I thought I could see some, look like a cleft here. So maybe there is some communication which is very small, which we do not see. So, and then I did some reading, literature review, and when we look at this, the content of the fluid is very thick, like a hingus, you know, there's the hingus. So I thought this is not lymphatic malformation. The lymphatic malformation are usually very, very diluted, just like watery, yellow color, but this is more yellowish than lymphatic malformation. Then I think back, I said, maybe this is not lymphatic malformation. When we look at the communication with the submandibular gland, maybe this is a ranula cyst. So I did some reading. Ranula cyst may benefit from Botox injection of the salivary gland. So we did a puncture to the lesion, aspirate, put a bleomycin here, and also inject Botox into the salivary gland, into the submandibular gland, the gland that is located very close to the cystic lesion. And this is in February 2022. And alhamdulillah, in April 2022, follow-up, no recurrence, only a small area. And this is the lesion. This is the lesion previously. And there is no more lesion, although you can see here, this patient is a regular gym gym attender. So dia ada angkat berat itu ini. So jadi dia very masculine. What you see here is the submandibular gland, and in fact you can see also the other side. Cuma di sini ada scar tissue because the operation was done before. And again, this patient I have not seen since April 2022 until now. Patient did not come to see me. Previously, almost every month or 2 months, every 2 months will come and see me. So this patient, but I keep contacting the patient. The patient said, no problem, Prof. I'm okay. No more recurrence. And I'm so happy for the patient. Therefore, I mean, it's treated. This is a 12 years old. I think I have shown this during our mass last year. So basically, similar, we thought is lymphatic malformation. And then we treat with bleomycin. We treat, and the problem is a few months before that, we had similar cases. We diagnosed as mesenteric or retroperitoneal lymphatic malformation. And this is the patient, our patient, current patient. We thought it's similar. This is lymphatic malformation. Then we treat with bleomycin 2 times, but no improvement. The first time we aspirated about, I think about 500 mils. Second time we aspirated about 1.5 liters of fluid. The fluid are exactly the same as lymphatic fluid, very diluted, watery, straw color. So we plan for third sclerotherapy, but I sit down and think about it. I said, are we treating the same disease? Are we treating lymphatic malformation? Because in my experience, once you give a bleomycin, it will help reduce the lesion. At least if it is not totally, at least 50% or 60% or 40% reduction. But this one, no reduction at all. It came back as a normal, as initial size. Therefore, we did MRI. I think we sit down and said, why not we review again our diagnosis and then do MRI. When I see the MRI, I can sort of see something like a capsule surrounding this lesion. Lymphatic malformation will insinuate in between here, but there's no insinuation. This is the left ovary. I don't see a right ovary. Therefore, I think this is unlikely to be a lymphatic malformation, maybe multicystic mass from the right ovary. Talk to the surgeon, ask the patient to go in, ask the surgeon to go in. Surgeon not confident. Surgeon said, let me do laparoscopic. I said, I don't think you can do laparoscopic because the lesion is very huge. How are you going to inflate air inside the abdomen where the abdomen is already distended? Again? So at the end, they operate the patient and came back as an ovarian tumor, huge ovarian tumor, 7.5 kilogram. And the moral of the story is not all multicystic lesions are lymphatic malformation. So the final diagnosis is mucinous borderline tumor of the right ovary. Okay, so classification tumor is a classification. History is important, especially in infantile hemangioma. So role of imaging, I will do ultrasound first, follow up by cross-sectional, either MRI or CT. If MRI is easily available, please do MRI. And not all multicystic lesions are lymphatic malformation. Okay. Teamwork is important. We work with we work with ENT surgeon, pediatric surgeon, oncology, in OT. Yeah. Thank you. Okay, Kun, that's all from me.
Thank you, Professor.
One hour.
Thank you very much, Professor, for the amazing lecture. We can learn a lot about the tumor versus non-tumor lesion, the classification of the lesions, the type of the pathology that we can see in imaging, the modality used to diagnose the lesion, and also there's something that I learned from this lecture is in learning radiology, we also can learn about the diagnosis pathology, but in the intervention radiology, we can also learn to let go of the patient. Yeah, as you said, because once they are finished with their problems, they will not return to practices like you said. Yeah. Okay. So We can jump to the next session, that is the question and answer session for the audiences.
Kun,
Yeah.
can we only allow 2 questions because I'm so sorry, I need to go at 2:15 I need to go. I got another meeting at 2:15.
Okay.
2:15 waktu Kuala Lumpur. Sorry.
Okay.
So we
Thank you,
allow
Prophet.
2 questions, and if you have more questions, you can ask me later, or when I go there, you can ask me.
No, okay.
Okay.
Okay, bro. Okay. So two question it is. So okay, for the audience that wants to ask a question to Prof. Zaini, the time is yours. You can open your mic, or you can write the question or in the chat room.
Thank you, Professor. Good afternoon, Prof. My name is Anissa from Radiology resident from Universitas Brawijaya. So my question is in patient with lymphatic malformation who underwent the sclerotherapy, when is the best time to evaluate the lesion and what modalities can we use? Should we perform MRI or maybe the ultrasound is enough? And also, what should we report it? Thank you, Prof.
Okay. So basically, we should do imaging as soon as possible. I would do ultrasound first. Basically, if I got a new case, the first thing I would do is ultrasound, because you can get a lot of answer from ultrasound. Number one, if there is any phlebolith, you can see phlebolith on ultrasound. Number two, you can do compressibility test. So if the lesion is compressible, you know this is a venous malformation. And number three, you can put color Doppler. You can decide whether this is very slow flow, no flow, or this is a very high flow vascular malformation or vascular tumor. Okay, and depend, some of the patient, if the lesion is very localized and superficial, you don't need to do. If you already confident with your diagnosis, presence of phlebolith and then compressibility. Even today, this morning, we had one patient who had a venous malformation at the supraclavicular region, only had ultrasound. Because we are confident this is venous malformation, we do not do MRI, we do sclerotherapy. So if you think that the lesion is big and you cannot assess the lesion fully, then you can do you can request MRI. Okay, so that you can have some rough idea how is the extension, whether the extension involves the important organ or not. Okay, hope I answered that question.
Yes, thank you, Professor.
Next question.
Yeah. Good afternoon, Prof.
Yeah. Dr. Indras.
Yeah. I will speak in bahasa Indonesia
Oh,
ya,
bisa,
Prof.
bisa. Bahasa Indonesia juga bisa. Ya.
Okay. Yeah. Your lecture is interesting, Prof. And ada pertanyaan dari kami, Prof. Ya.
Yeah.
Pada kasus lymphatic malformation ataupun venolymphatic malformation, ya. Itu kapan dilakukan injeksi bleomycin, kapan dilakukan operatif, Prof?
Oke.
Ya.
Oke. So sekarang ni di center saya dan juga I would think most of the center, sebab kita juga dapat rujukan ataupun referral dari hospital-hospital di utara, di selatan. Basically, the main treatment is sclerotherapy. Even our surgeon also will ask sclerotherapy first, and if let's say the lesion has become small and tidak boleh kelihatan lagi, then okay, cukup. Tapi kalau lesi itu tidak bertindak balas dengan sclerotherapy, ataupun dia cuma mengecil cuma 90%, dan ada pada lokasi-lokasi yang tidak cantik kelihatan, then we have plastic surgeon in our team. Therefore, because kita ada multidisciplinary team for vascular anomalies, so plastic surgeon kita akan minta opinion plastic surgeon, dan plastic surgeon akan tengok kalau dia rasa this is a good time for the kids to have plastic surgery, then dia akan decide. Macam anak yang besar tadi tu, walaupun sekarang tinggal residual sedikit aja, tapi kulitnya berkeredut kan, jadi tidak cantik. Jadi I think the plan for surgery is in October, because kalau kita tengok lesi yang cystic tu sudah tinggal sedikit sangat. Jadi since they are going in for the skin reconstruction, therefore they will remove whatever residual tumor there. So secara dasarnya treatmentnya adalah scleroterapi dulu, kemudian kalau perlu plastik surgery baru ni. Pengalaman saya setakat ni surgery tidak mau pergi go in, because surgery juga tidak senang, tidak baik juga. I mean kan, tidak semudah yang kita sangka, especially bila the lesi itu insinuate in between the tissue, so that make them make operasi itu susah. Ya, Dr. Indras harap menjawab soalannya.
And ya, oke.
Okay.
Kalau begini, Prof, usually, halo, ya, lymphatic malformation or venous malformation is multicystic, ya, multicystic lesion. Oke. Nah, what's that? Sclerotherapy injection itu masuk di salah satu sistiknya atau menembus dindingnya itu, Prof?
Oke.
Ya kan multicystic lesion. Ya.
So dia begini. Masa kita plan kita punya treatment. So sebab itu saya suka treatment kita buat di Dewan Bedah yang ada fluoroskopi ataupun di angio lah, angiografi. Sebab satu, dia ada multicystic. Contohnya lymphatic malformation, dia ada multicystic. Kadang-kadang kita assume there is communication in between locule itu, in between cyst tu. Tapi sebenarnya tidak. Ada pengalaman saya, ada yang tidak bersambung. Okay. Kalau kita treat yang certain locule itu saja, certain locule itu yang akan mengecil. So locule lain tidak. So kalau ada dua strategi. Nombor satu, kita treat yang itu saja, kita follow up tengok yang ini aja yang kecut, yang lain tidak kecut ya. Jadi kita treat yang tidak kecut pula satu-satu. Ataupun we can do it together. Sekarang saya lebih melakukan approach ini. Maksudnya dalam satu sitting itu kita buat semua sekali. Sebanyak mungkin yang kita boleh akses. Bagaimana? Saya akan puncture the cyst tu, saya inject kontras. Kalau kontrasnya masuk dalam satu atau dua locule, tapi ultrasound kita nampak 10. Jadi kita tahu dia tidak berkomunikasi. Ya. So jadi kita puncture satu lagi, masukkan kontras lagi. Jadi dia tambah lagi 3. So ada lagi 3 contohnya. So kita cari lagi, sebab bila kita under ultrasound, bila kita masukkan sel line ataupun ubat sel line, bila kita puncture, kita inject air sedikit. Kita tahu locule itu di mana. So ada locule yang tidak bergerak langsung airnya, kita tahu itu yang tidak komunikasi. Jadi kita puncture yang itu pula. Jadi kalau kita buat strategi macam ni, the effect of our treatment will be faster, dan mungkin 1 atau 2 treatment saja sudah cukup. Berbanding dengan yang strategi yang pertama tadi, kita try dulu. Lepas tu next time tengok yang mana yang kecil, yang mana tak yang besar, masih lagi besar. Next, second follow up. Jadi lebih baik kita, sebab tu sekarang saya punya strategi lebih kepada multiple puncture. Dulu saya 1 puncture aja. Okay? Okay. Terima kasih banyak-banyak.
Ya, terima kasih banyak.
Saya harap saya menjawab soalan Dr. Indras.
Ya, sudah. Terima kasih, Prof. Ya, saya kembalikan ke Dr. Adi.
Okay. Okay, thank you very much, Dr. Indras, for the question. And thank you very much, Dr. Nis, for the question. We can learn, and thank you very much for Professor Abdaini.
Boleh. One last question from Agung. Silakan.
Okay, Dr. Agung.
Prof, after you did ejection bleomycin, what do you do for the patient? Do you compress the in the lesson? Do you compression?
Okay, kalau lymphatic malformation, usually I will not do compression. Tapi kalau venous malformation, selalunya saya akan do compression. Because number satu, compression itu juga akan membantu supaya kalau ada draining vein, dia akan block the draining veins. Nombor satu. Nombor dua, kita nak supaya bleomycin itu ada direct contact dengan wall of the lesion. Bila kita do compression, basically bleomycin yang tu akan lebih mudah untuk kena pada wall dan efeknya akan lebih baik.
Yeah. Thank you, Prof.
Okay.
Okay. Thank you, Dr. Agung, for the question. And thank you very much, Prof. Hamzaini. And now this is the end of this afternoon's lecture. Thank you very much for the audience, for the attention, and thank you very much for Prof. Hamzaini for giving us amazing lecture. Thank you very much, Prof. Hamzaini. And before we close our session, there's going to be a photo shoot, Prof. So we're going to take several pictures. So please, the audiences, if you don't mind, please open up the camera, and we're going to take several pictures. Okay. So now for the first page, we're going to take the picture in 1, 2, 3. Okay, and now for the second page, we're going to take a picture in 1, 2, and 3. And for the third page, we're going to take a picture in 1, 2, and 3. Okay. And the fourth and the last page is we're going to take the picture in 1, 2, and 3. Okay, that will be our final agenda in this afternoon's meeting. Thank you very much to all of the audiences, and thank you very much to all the professors, my dear lecturers, and Prof. Hamzaini. We're looking forward to meeting you again in another occasion, Prof. Hamzaini. So yeah, thank you very much, Prof. Hamzaini, and that is all for this meeting. I hope you guys, that all the audiences enjoy the lectures and can learn in a substantial amount, and so that we can meet in another beautiful occasion. Thank you very much, doctors and professors. Have a beautiful afternoon. Thank you.
Thank you everyone. So, saya mohon untuk keluar dulu ya. Terima kasih semua. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Agung sudah teringin rawon iganya.
Boleh, Prof. Boleh, Prof.
Oke.
Ditunggu, Prof. Ditunggu.
Insyaallah. Oke.
Ya, Prof. Sehat-sehat.
Dr. Prayuyun, Dr. Indras, thank you. Oke. Assalamualaikum warahmatullahi wabarakatuh.
Dan Dr. Nurul.
Dr. Nurul, terima kasih.
Prof Ham sudah nggak ada. Prof Ham mau ke Aceh loh, ke Dr. Nurul. Iya.
Oke, pamit.
Oke.
Ada aktivitas hari ini.
USK
Assalamualaikum, kami pamit.